As Jared said, my name is Stephen Johnson. I work at the Department of Health in England, and I was asked to come across here today to talk about technology and the place it has in healthcare. And as Jared has told you, my interest is in telehealth and telecare. So I started thinking, how does that fit with what you people were talking about today? So I started thinking, well, what's stopping us? What's the difference? Why aren't we doing this? Telehealth, telecare, technology, telemedicine, whatever you want to call it, it's been around for a long time. And it got me thinking again, what is the difference? And as it says on there, what is the difference between a stethoscope and telehealth? Any form of technology that's supporting people is essentially about getting information from the user to someone else. And that could be a carer, it could be a professional, it could be indeed the user themselves. But it's about supporting people making decisions for themselves. And the reason I thought about stethoscope is everybody's seen the pictures of doctors with the stethoscope around the neck. Think back a couple of hundred years. Before stethoscope, what did we do? Somebody would use their ear against someone's chest. Then you would get a trumpet against the ear to magnify the sound. Then we got stethoscopes. That's technology. It's just a very low-tech rather than high-tech. So the point of what I'm trying to say, and the reason I wanted to look at it this way, is it's about recognizing that technology isn't something which is new, it isn't something which is scary, and it isn't something that we should be trying to fit around. We should be using it in our everyday dealings with healthcare and people's lives. So, what's stopping us? I keep coming back to that point. What's stopping us using it? We use it in everyday life. I'm stood here using a laptop, I'm using a microphone. We use it in every aspect of our modern lives. And yet when it comes to people's healthcare, we stop and we wonder, does it work? Can we actually use this for the benefit of the individual as well as the benefit of the service? And it comes back to this simple question, does it work? That's what people always ask me. That's what I keep getting when I go around the countries that I've visited. Does it work? That's the simple question. Well, my answer to that is the freedom to choose what you want to do with your life, as I think the last speaker said in the session before lunch. That freedom to choose what you want to do with your life is important. And it's going to become the norm. People will want to have their lives their care reflect their lives, not the other way around, not be fit into a system that currently exists. And let's not forget that tomorrow's decision makers, the people who will be in both the medical profession or in politics, doing the policy, the people who are providing the care, and indeed the people who are receiving the care. These are the 20-somethings, the teenagers of today. They're not going to stop and say in a conference like this, oh, does technology work? Should we have it? They've grown up with it. They're not going to be concerned about whether it's the right or wrong thing to do. It's just been there all the time. So my argument will continue to be, for as long as I can stand in places like this, that people want to live their lives as they want. They don't want to spend day upon day in hospital. They don't want to be tied to the idea of going into and out of clinics, bricks and mortar, buildings, when there is an alternative. And that alternative is to support people to make the decisions for themselves, to live the lives that they want to live. Technology can support that. And all we need to remember is that that is going to happen. The technology exists now, it's going to improve, it's going to develop. People who are currently growing up with it are going to use it. The question, I think, for us is how do we make it happen quickly? And I just wanted to raise this issue. Nothing's new. MRI scanners. Most people have heard of them. Full body scans allows diagnosis, allows people to be given messages or news about their health. It allows medics to make clear diagnosis. The actual approach started actually back in the 1940s, but the actual scanners were first invented in the 70s, the 1970s. By the 1980s, they became quite commercialized. They were still quite expensive, but they were commercialized. By the 1990s, they became widespread. People started using them. And those of us who've been in healthcare for some time will remember, you know, the 1990s was a time of appeals for a scanner in the local hospital. And by the early 21st century, they're commonplace. The point I'm making is it's taken a long time to go from the technology exists to be it's seen as commonplace. As much as 30 years, and that's not uncommon. Again, I come back to my argument. Why are we waiting? Why do we have to wait for so long for these things to become commonplace? And I would argue with telehealth and telecare, and what I mean by that is that telehealth is an opportunity to use devices in the home usually, which monitor your vital health signs, blood pressure, pulse, etc. Those signals are then sent remotely to a health professional who can make instant decisions about someone's state of health, but it also allows the individual using the equipment to make decisions about themselves, to understand what's happening to them. Telecare are devices which are often in the home or in a home environment to support people who live independently. They can be the simple pendant alarm, for example. If you fall, you can press a button, someone comes to your aid. But there's lots of different devices. And my argument is, why are we waiting? These things have been a long time, been around a long time. Why are we waiting? We don't have the time to wait 30 years for their adoption. We know they work. We know they make a difference to people's lives. So what's stopping us? And I think a lot of it is the fear of the unknown. So what we decided to do in England was to put to bed once and for all the biggest single barrier to the delivery of this, and that is, does it work? Go back to one of my earlier slides. Where's the evidence, people ask? So we set up something called the Whole System Demonstrator Programme, and this has taken about 5 years to get to the point where we are now, which is we're almost ready to publish some results. It was a randomized control trial, and that's essentially because we needed to make sure that we had what we thought was a gold standard of evidence for clinical colleagues. Most randomized control trials of any, whether it's equipment or approaches, are of tens of people, sometimes in the hundreds, 200-300 of people. We deliberately set out to do this at a grand scale, and we looked at over 6,000 people being recruited to the program. 238 GP practices were involved. The reason I'm giving out those numbers, it was on a scale which is unprecedented. And I would again argue that the results from this will give us not just does it work, but it will give us a position of probably the most pessimistic that you can have because of the rigor of the trial. There's plenty of evidence out there that it does work, but this is pure evaluation. This is something that can't be argued with. And the purpose of the program, and I've just put up 5 bullet points there. We wanted to know whether in the long term it improved well-being and independence, whether it improved the quality of life for not just the people using the equipment, but their carers as well, whether it had an effect on the working lives of staff, whether it was cost-effective, clinically effective, and give us an evidence base to go forward. Unfortunately, I'm not able to put up a table showing you all the results because the evaluation team are still working through many volumes of data to get us the results. What I can say today, though, is that it's going in the direction that we would expect it to. We're starting to see some evidence that all the other trials and studies that have been done on a much smaller scale are not without substance. So all of the issues as far as technology, and particularly telehealth and telecare is concerned, is that it's not about the technology. It's not about going off and getting the best new machine that has the most flashing lights and does the most innovative technical issue. That's not going to make the difference. What makes the difference is building it into the service that you're delivering. You have to look at the service change, and you need to build it around the individual. Then you put the technology in, and then you'll start to see some of the benefits. The message is clear. Give people support where they want it, in the way that they need it. Not, this is the service, try and use it and try and fit into it. And I'll just leave you with some quotes that we've taken from the people. These are real quotes from real people in the study. Living on my own, it's nice to know I can call for help if I feel ill during the night or fall. The alarm system allows me a lot more freedom and peace of mind. It means that I don't have to go into a care home, which I don't want to do. I want to stay in my own home for as long as possible. I feel much more confident knowing that someone is keeping an eye on my health every day. I think it's great. And since I started using telehealth, I've been able to manage my condition better. It changes the whole concept of my life. I can get on with my daily activities, and I'm totally independent. I've got lots of those, and those are real people. I have been to people's homes and spoken to them. I've asked them, what's the best single thing about this approach? And every time I get told it's about supporting me to do the things that I want to do, it prevents me being forced into a box marked whatever their condition is. It gives me the freedom. And one lady in Blackpool said to me, young man, she said, and I loved her for that, she said, young man, make sure people get the benefit of this. It works. And she was a lady with many multiple long-term conditions, end of life, and she had just recently been admitted to hospital. And while she was in hospital, they took away her medications, they took away her telehealth, and they did it all for the best intentions. And she told me that she felt unsafe in hospital as a result because she was denied the independence, she was denied the opportunity to make decisions for herself. Subsequently, she discharged herself against the wishes of the consultant, went home, connected herself back up to her support systems, used her telehealth, got her senior community matron support again, and was able to manage her life in the way that she wanted, and she felt much better for that. So again, going back to the beginning, it's not about what equipment exists, what technology is there, or the question of how does it support people's health. The question that we all need to ask is it works, it's there, we have evidence. We've got more evidence coming on telehealth and telecare. The question we should be asking ourselves is why aren't we using it? Why isn't it being developed for people to use for their advantages? So I just wanted to leave you with that thought, rather than trying to second guess what's coming down the track in terms of the new equipment that's being devised, whatever it is, whatever the adaptations or whatever the technology is. Ask yourself the question, why isn't it being used? And you'll find the answer. Most of the answers are evidence, cost, awareness, and staff training. Meet those issues head on, but ultimately, don't give in to those people who say, it doesn't work, I don't like it, it won't be good for me. Because all the evidence suggests it does work, people love it, you can't take it away from them once they've had it. Ask the question, why aren't we using it? So thank you very much, and I hope that's been of some help, and good luck with the rest of today.
Thank you very much, Stephen. I'm going to take two quick questions from the floor because Stephen has a taxi throttle to the floor outside the door. So Siobhan here in the front. Thanks, Stephen.
Thanks very much, Steve. Could I ask, just in terms of a lot of what you spoke about related to health, and just in terms of telecare and kind of care supports so people can live independently as opposed to maybe having a dependence on medical type of services, but also when you talk about the how you can make it work, that it's not just about the technology, it's obviously about all the joined up pieces behind and people connected in within services and across services. Could you tell me a little bit more about that?
I think it's essentially the message I'm giving is it's about service change. You work with the individual. When it comes to chronic health, long-term conditions and individual care, I would argue that the issue is care planning. Sit with that person. So the professionals need to ask the people, what are their goals in life? What do they want to achieve? Much in the way that Rachel Johnson talked about what was happening in Brisbane. Sit down, ask people. Once you know what they want, you can devise a program for them rather than devise a program which you think they need. And so to do that, you need health, social care, sometimes housing, often transport, all coordinated in a way which works for that individual. Lots of different barriers to that. There's obviously issues about funding and different budget pots. And again, it doesn't matter which country you're in, those issues are real. But again, if you work to the individual and everybody's committed to it, you will get that change. So you need top-level buy-in, you need the clinicians to be supportive, and you need to be able to empower the people who are receiving the services to ask for what they want. And that's how you get that joined-up feeling to the service.
Very good. Thanks very much, Stephen. One last question from the floor. Great. Just.
Thanks, Stephen, for your thoughts. How quickly is it going to move from home out into the community so that people are not just able to avail of the services in the home environment, but also going out, meeting friends, going on holiday, that sort of thing? And is the biggest constraint going to be financial for that?
The constraint isn't financial. The constraint at this current time for what you're talking about is the ability of the technology to keep demand and pace with that type of approach. But it's coming. I have seen devices which you wear. I've seen devices that are implantable. I've even seen and heard of a device in the States where it's basically a scanner that you use at about a meter from the individual, and that will give you the readings of blood pressure, blood flow, blood oxygen level, that sort of thing. These are very expensive items at the moment, but as they start to become more commonplace, the costs fall. But the issue at the moment is, let's get a grounding, let's get a baseline from where we can actually build. You need your foundations, so we need to get something where we use the technology that exists now. It will move to mobile device, and it will move to things that you wear, or maybe even, as I say, implantable chips, that sort of thing. But it's coming. I think, and I've had this argument with a number of people recently, I think it's less than 10 to 15 years before we get into that mobile area. But let's have the foundations to start with.